know something more about it, which I will come to it at the end of my talk. So let us first discuss what are the ethical challenges in organ allocations for heart transplants. As I am the only non-cardiologist available in this room, so let me just quickly and briefly introduce consent for surgery. We always are now recommending on behalf of the West Bengal Medical Council, not only for the transplant patients, in other cases also, when you are dealing with the complicated procedures, do.
Then that depends upon the professional piece of the surgeon and the professional piece of the manpower.
Yeah, so that can vary, that depends.
Can vary, depends upon the type of the hospital,
Absolutely.
hospital, corporate hospital, 5-star hospital. But average cost is 10 lakhs.
Yeah. So that
We are
paper,
talking about with the stage
With the stay, with the immunosuppressants, with one biopsy, with angiogrammatic discharge and the procedure. How much?
Inclusive complications. Inclusive complications.
I'm not talking about complications.
no, sir, obviously you cannot predict all complications and all the costs, but on an average, I think 10 lakhs is a reasonable figure. The only paper that has been published on Indian patients, the largest series was by Dr. Bala. The cost there was 14.5 lakhs. And it matches the amount that is paid in the south, in some of the states. The government pays about 15 lakhs. So I think it's a very, very reasonable figure. Now, I don't know, I'm sure in 7 lakhs in government hospitals is possible, but corporate hospitals work in a different way. And they have to account for other expenses, but let's not get into that. Now, question is, how can we reduce this funding? Do you think that there are some points and you can choose whichever point you want to talk on? Now, yes.
See, when the Karnataka government started funding transplants for BPL, I ran every transplant center in the state and said, please take this. Because if you don't utilize it, next year the government won't pay it. So it is my interest also that you utilize it. But they have to make it.
So CGHS pays about 15 lakhs. I mean,
I think in our situation, when this happens, then we have a team of doctors, clergy, and so on and so forth, which will go and see the patient, see the family, and discuss that and discuss the end of life. So it's not a situation where you would say, right, okay, you don't want the treatment, you can go home. So there's end of life treatment, and that's the process that we take. And that starts, and that may take many days or weeks. So I think this is the way, and it is done with the consultation. I mean, you have patients say no, you don't say, right, okay, that's it, you're out. So you still have a chat with the family, you still will have a chat with the patient and see if you can come in any other direction.
thank you. So,
as doctors, are we right in understanding, supposing a situation now, patient is not in a corpus mentis condition to make a decision. Doctor thinks a treatment can go on. The relatives seems reluctant. In that situation, was there, I'm not clear on this, is there a ground for the hospital or the treating doctor to approach a court for directions? That what do I do in this matter? Do I treat or do not treat? Is there a ground? Because you see, today we do get patients, say somebody, an octogenarian getting admitted, who makes a clear cut say, I am not to be maintained. End of story. Those are pre-made decisions, do not go beyond this line. But that in our society is not very common so far.
Except in cases relating to abortions.
In
respect of abortions, they have to take the permission of the court.
That's a different matter.
No, permission of the court. You said the permission of the court.
Yeah,
That's in abortions you have to take the permission.
We are going to subsidize, or you may subsidize, and we can have some kind of CSR activity from there. Have a pool from one source throughout the country where we can sort of, send the medications to such people, and poor people have to be subsidized. There's no doubt.
I think more of a problem is with anti-fungal more expensive medication. Immunosuppression, a lot of times is covered by the government side, at least another government does it. But if you get a complication, suppose you get AMR, every treatment modality for AMR is very expensive. So these are not covered by anybody.
I think Dheeraj, that's the last comment that's going to be because we've got 20 seconds. That was the question.
No,
I
understand, but what I'm saying
I'm
is that
explaining my point.
documenting that,
Yeah.
because otherwise you have to keep yourself legally, medico-legally safe.
Pediatric transplant patients, mTOR-based regimens have lower chances of renal dysfunction, lower chances of PTLD, and lower chance of CMV reactivation. That monotherapy may be considered in selective cases. It gets a class 2C recommendations according to the 2022 ISHLT guidelines. De novo mTOR inhibitor regimens completely CNI-free now we know have good long-term survival data. And finally, and most importantly, selecting the most appropriate.
Most of the topic has already been covered during the course of the day. So we may sort of just fill in some of the things. If there are not enough chairs, we can get you some more. There are a couple of chairs here, please. Okay. So I'm assuming that everybody who was meant to be here is here. I'll go straight into the meat of the panel discussion. The slides are not moving, unfortunately. Next slide, please. We can move.
Together, till August 2025, we are at 45. And the
To be much benefit, the prognosis is very poor. Do you think in a country like ours is a good option to continue with the treatment because the family or the patient wants, or should you use that bed for people who have simpler things which they can get better and go home?
Exactly. I think most important thing to decide in this sort of situation is futility of care. Now, whether it is futile to continue treatment in the patient, that particular patient, is the patient going to survive? Is the patient going to get better, get out of ICU, go home? These are kind of things you have to consider. Now, how do you decide? Now, ISCCM and Indian Society of Palliative Care Medicine, they have made a joint statement and sort of a pledge to the government, position statement, where they have mentioned that in these sort of situations, you can go for a medical board. First is a primary medical board, to be followed by secondary medical board. So primary medical board will consist of 3 clinicians with at least 5 years of experience who are part of the treating team. But a secondary medical board will not be part of the treating team, that will be a different team. And one of them has to be ratified by the government or the legal authorities to be a member of that committee or that board. Now the question is that if after primary medical board the relatives agree with the decision of the doctors that it is futile to continue care, then only you go to secondary medical board. Otherwise there is no point. If relatives don't agree, they say, we have got money, you just keep on the ventilator, we'll pray to God, we are going to temple, and we are sort of, fine. So, but there's one thing, last thing, two things I would like to mention is that now some states have issued guidelines like Kerala, Gujarat, and all that. Now here is a state subject. In West Bengal, still we are waiting for some guidelines. Number one. Number two is that there is no need to take permission from court. You just inform the judicial magistrate. That is what the rule in other states. Like Kerala and Gujarat, to name 1 or 2 states who have made these rules. And last thing I would like to mention is that all the discussions that were happening, I was raising my hand. I was just trying to say that when patient is alive, obviously, yes, this compost scientist is making a decision. But if the patient dies, and when you are in court or even in counsel, the patient is not there to defend you and to say that I have refused. So document it very clearly.
Finding out new age types that are there, and then there was this need to multiplex and detect more antibodies against the n number of antigens.
Outset, I would like to thank the organizers of this conference to allow me to talk here on a very important topic, that is ethical challenges in organ allocations for heart transplant patients. Now, as I understand that